everyone join me in welcoming now to the stage Congressman Brett Guthrie, who currently serves on the House Energy and Commerce Committee representing Central Kentucky. Protecting Medicare is one of his top priorities as well. And joining him on stage is my colleague, the Hill's Editor-in-Chief, Bob Cusack. Bob, over to you.
Thank you. Thank you, Brittany. And thank you, Congressman, for joining us
Good morning.
this
Great
morning.
to see everyone.
Kind of a big, broad question. Just what are your constituents back home? What are they talking about on healthcare in general, Medicare Part D? What are they talking about the Mueller report, or are they talking about other issues?
Well, actually, you'll hear people in passing on the Mueller report on what's kind of going on in D.C. and can't people get along better? And
Right.
Maybe you heard a little earlier that we actually, from Doris, we do get along better than people think we do. But, you know, the specific issue is robocalls. I'm afraid I get that more than anything
Really?
in general. But on Medicare Part D, you don't really hear a lot of complaints about Medicare Part D. And I was just in that program in specific, which probably shows the program is working. When I was in the state legislature when it passed, and I remember the efforts of different groups trying to be concerned about the rollout of Medicare Part D, and the big concern is going to be complicated, it's going to be confusing, and seniors are going to be confused. And I wasn't here when that happened, so if that was the case at the time, it doesn't appear to be so now. And you know, people have up to 20 different choices, depending on 20 to 25 on average choices. So it seems to be a program that's working. So we have to be careful when we modernize something that's already working, that we don't have unintended consequences. But the issue that I hear specifically is just the costs, not necessarily Medicare Part D, but the cost. And have a group of people that gather every Saturday in my hometown to drink coffee. And so if I want to hear what's going on in the local city council or whatever, those are the guys to find out. And there's one in our group that's a senior that does have cancer, is in treatment, and he's one. Most of us are kind of my side of the aisle, but he's the one that's not. And so matter of fact, this Saturday, he always has a question I have to answer. This Saturday, he says, "Does Jim Jordan want to borrow one of my jackets?" That was his thing. And I just looked at it and said, "Well, at least now I know you watch Fox sometimes." But he literally, I walked in one day and he pulled this vial out of his pocket and he said, I think he said 10. If I remember, it was a few months ago, 10 or almost a year ago, 10,000. This is $10,000. It was his cancer drug. And what do you think of that? And I said, well, what's the context of it? And that gets to what the president did yesterday. I mean, what's the value? Is it a blockbuster drug? Is it new? Is it changing? You don't have to go to the hospital. You're not in those kinds of things. Or is it something that's been around a while that a hedge fund bought and now they're just raising the price? And it just showed that the issue, that to get to your point, the issue, and for him as an example, is we don't know the value. I mean, it's hard to tell what the value. Some things are worth that because it completely is changing people's lives. And preventing hospital stays and other types of things. And some of them, you just don't know. We're getting to this, which we can get into as well. Get to your next question, I'm not going to, but we're getting into the list price and net price and those types of things. And when he quoted me 10,000, that mean, is that what's on the list, but your plan only played 2? I mean, that shows how confusing our system is.
And what's the remedy?
Well, I think the president started with it yesterday. I can tell you of all the things that I'm involved in, I'm not one, because I'm not on the Judiciary Committee and a lot of stuff that is kind of popular out in the public to watch on television. So going to the White House to meet with the president, I typically don't do. But once I was there on drug pricing. So I know the president's focused. He would love to see us come together and come up with a solution to drug pricing, and he dealt with it a little bit yesterday with transparency. I think letting people know what it costs, and then Medicare Part D in general, as we're starting to modernize, because there's no transparency, there's no downward pressure on price at the high end once people are through what used to be called the coverage gap, but I know it's now, the gap has been closed through the ACA. But there's different things that happen within the coverage gap, and then it gets to the other end, and Medicare pays 80%. And I know there's the proposal the president's had in his budget, and the proposal from Ways and Means, from Energy and Commerce, bipartisan, to have the plans have 80% and 20% for Medicare, to try to put more downward pressure on prices at the high end. Because the biggest drivers seem to, well, there's more of us, I'm 55 now, so there's more of us going towards Medicare. I'm the end of the baby boom. But a big part of people are going away from generics. They're not adapting generics at the same level they were at the early part of it. And then these specialty drugs that are truly, and when we say those, can be completely life-changing. but they are expensive.
As far as bipartisanship, you serve on the Energy and Commerce Committee. You have a good relationship with Congresswoman Matt Suey. Do you see bipartisan, there's a lot of legislation that's bipartisan, as you said, mentioned both in the House and the Senate, pending right now, but the 2020 season's already started. So is something going to get done, and you think a deadline's got to get done, by the fall or later this year?
Well, I hope so. We passed some bills that came out of committee bipartisan, ended up passing the floor because they got changed in the Rules Committee, dealing with drug pricing. A lot of it is how do we get generics adopted quicker, and how do we have generics to the marketplace quicker? And so I think those can happen. And I know the president, I'm not going to speak for him, but I know he wants something to happen in this space. So I'm not saying he's going to sign which bill passed or which bill didn't pass. But I do think that this fall probably would be the right time to get it done by this fall. You could put a group together, say, let's hammer out some true drug pricing, transparency, drug pricing strategies, where you look at this is just the way things are on formularies, the way things are priced, net price versus list price. We could really sit down and hammer out, I think, a deal that the president would sign that would make life better for people in the country. But I think you're pushing the fall is probably the time that needs to happen.
Yeah. As far as bipartisanship in healthcare, and of course the Affordable Care Act is something that divides the party bitterly, but the Energy and Commerce Committee has worked on a number of bills over the years, 21st Century Cures Act, which we've talked about on the stage a lot.
Comprehensive,
opioids,
comprehensive recovery Act.
But does that get in the way? It seems like it gets in the way because that's always going to come into some type of the conversation of Obamacare, and then does that get in the way of bipartisanship on any healthcare bill?
Well, it did on the drug pricing bills.
It did,
What had happened is we passed a set of drug pricing bills, I think by voice actually out of committee. If not, it was strongly, if I remember correctly. And then once they got to the floor, they were put together with bills to help improve or bail out or whatever the right word you want to say on the Affordable Care Act. And so they didn't pass partisan. So they're going to have to separate them, I think, and move forward on that. Hopefully we can do that.
Do you think there can be deal making now with, such a vitriolic time, it seems?
I think so. And you got to pick those different spaces. And when you say vitriolic times, you look at what's going on in the Mueller report and those types of things. I think in this space, with the president wanting to get it done, with a majority in the House wanting to get drug pricing done, I know senators wanting to get something done. If this is not one area we can rally around and get it done, then they won't be able to do anything, I don't think.
The Trump administration has a new plan, final rule to reform Medicare Part D, deals with the 6 categories of drugs.
Right.
How do you think the administration has done on this rule in particular and in general on healthcare?
Well, in the 6 categories, I think they've backed off of that some. But the issue that seems to be, if you look at so Medicare Part D is actually performed under budget, as most people follow this in here know that. It's one program that actually has performed under the predictions. It seems to be widely popular. People like the program, and so we have to be careful as we move forward. But the predictions, if you look at, there's a CRS report that is really going to exponentially increase as we move forward. And a couple of things, number of baby boomers coming forward. But the 2 big things is the mix of generics versus name brands and these specialty drugs that are coming out and moving forward. And so I think the administration is trying to, how do we get a handle on these specialty drugs? And the 6 categories is one way that they went forward. They've since backed off. I think maybe a better way to do it is the administration has done, and we're looking at doing or administration has proposed, and we're looking at doing, is that you have, instead of 80% Medicare at the catastrophic level, we go to 20% Medicare and 80% plans. And I think another way that's not in our proposal, but something I think that's worth discussing is, because as you move, if you're a Medicare Part D recipient, as you move through, you're in the early stages. If you get to what we used to call the coverage gap, which isn't really coverage gap anymore because you're not paying 100%, you're paying 25% now. But the 70% are the pharmaceutical companies, and they give discounts to get you through the coverage gap. Then you get to catastrophic, and maybe instead of having the pharmaceutical companies 70% in the middle, we smooth that out, that they still have some stake in the game as you get to the catastrophic phase. So that puts pressure on pricing as well. If the pharmaceutical companies, manufacturers have some pressure as we get to the catastrophic to make sure their prices aren't too high, because they have some skin in the game as well. I think we need to look at that. I think that should be part of the debate.
You mentioned that Medicare Part D has come under costs and certainly under the cost that CBO projected, as well way under the cost that CMS projected at the time. And Part D was created in what was going to be a 15-minute vote on the House floor. It ended up being 3 hours. I was there that night, and there were only 20 people in the press gallery that night. Now there would be 300. But so it was a very kind of a volatile start because there were conservatives who balked at the program because it wasn't paid for and pricey, and that included Mike Pence and Jeff Flake. But the program has been successful. You don't hear Democrats, even after they took back the House, of repealing what Republicans did on Part D. But what is the model? So this was a Republican plan, basically. Republican Congress, Republican President George W. Bush. How is that could be a model, obviously, but on a broader scale, for what Republicans have struggled to do and come up with a unified health care plan?
Well, the model with it is that it allowed the competition to work in the system. So you had the pharmaceutical companies, the health insurance plans negotiate prices amongst themselves. And there's a push, you look at, it's not in this modernization kind of proposal that's moved forward through Ways and Means or been proposed, not moved forward, but put out there through Ways and Means and Energy and Commerce. But you hear a lot of people say, well, the federal government should negotiate these drug prices. And if you look at CMS and particularly CBO, they said there won't be any savings because you get the dynamic between trying to get on a formulary, getting price to get on a formulary, and the health insurance plans wanting to have more drugs on their formulary because people have choices, that is what's kept the price down and move forward. So the model there needs to be competition. There needs to be marketplaces within the system. When you get to the point where there's just absolutely no market, that's when people become indifferent to prices. You have transparency in prices, and we have the problems I think we have in our health insurance system today that we're still trying to address.
Now, contrast it to the Democratic health care plans. Debates are this week for the presidential primary. There are some candidates that support Medicare for all. There are others that support a public option or expanding Medicare, buying into Medicare. Why do you think those are bad ideas?
Well, I think that we need to keep it as private as we can. The government certainly is a big player in health insurance, and we're not going to change the fact that we're in Medicare and that Medicaid's a substantial program. But I do think that the dynamic we have in our country, they don't have in other countries, it leads to the innovation that we have. I was with Dr. Francis Collins the other day, and he says, I'm going to use the word cure. I'm going to say the word cure. We can cure sickle cell anemia. Now, that's not through a drug, a pharmaceutical, it's through a procedure, but we literally can cure it now. So people who go through the process, which involves, I'm not a physician, but it involves, I think, a bone marrow transplant and some other thing, and genetic manipulation, but go through the process. When you test them, it's like they never had it before. We have that. We have the artificial pancreas that's out there now. We just, so hepatitis C can be cured with a pharmaceutical, which is expensive, but it saves liver transplants in the end and makes livers more available for people who have other kind of issues. So my concern, if we go more towards single payer and we get to the point that other countries seem to have, you look at other countries that have limited formularies, they have wait times, they have a lot of issues that we don't have here. Of course, ours is expensive, but we do get the innovation that I don't think you get anywhere else in the world. It is happening. It is real. People with stage 4 melanoma now Dr. Francis Collins says, I will not use the word cure for people with, not everybody with stage 4, certain types of stage 4 melanoma. There are people who live a long life who are already in stage 4 melanoma because of some of these T-cell kind of different procedures that are coming forward. And I'm not one to say the government backs out of it, because the mapping of the genome that was funded, that you couldn't really get private industry to do that, because what's the commercial viability of that? Well, you see it now. You have a lot of private equity investing in bio firms who are coming up with these wonderful treatments based on research from the government. So we work it together. But if you take that private aspect out of it, I believe, in the competition and the profit motive, then you're going to take out that drive to innovate that we truly are. It's just amazing what's happened in the last 10 years.
What's the feedback you get being on one of the key healthcare committees? feedback you get from provider groups about Medicare, healthcare in general?
The biggest issue with provider groups are reimbursements. I mean, you hear that with reimbursements. And I would say most providers, I don't know if you have provider groups in here, people represent provider groups, but say if we had to exist only on what the reimbursement is for Medicaid and Medicare, we couldn't. So you could get to Medicare for all, that we couldn't exist. And so there are a lot of price transfers from people in private insurance, people who private pay, people who move forward to cover for people who to cover for the lack of payments through Medicare and Medicaid. So that is the biggest concern that you have from hospitals, you have from provider groups, and just the pressure, you hear a lot of it from the bureaucratic pressure. You know, we went with the medical health records, which was mandated in the Affordable Care Act, which we need to get to. I'm not criticizing that aspect, but then you have a lot of providers say, I spend more time creating records than I'm seeing patients. And so we have to figure that part out of it, that part too as well. But I think we do need to move to that. I mean, I had to find shot records when I was a kid to go to a certain graduate school when I was 31. My doctor was gone. He no longer had the piece of paper that had my shot records. I got my MMR again when I was 30, but just so I could go to grad school. But so now that should all be electronic and should be in the person's possession. So I agree with that idea. But it has caused a lot of effort outside of just taking care of patients at physicians. It's just the overhead of a physician's office is what you hear a lot about.
Sure. We'll open it for questions in a couple minutes. But when you think of Medicare in general, what keeps you up? Is it the aging? You mentioned the aging population. Medicare is going bankrupt here. You know, it's not in vogue to talk about kind of those type of things now.
Right.
You don't hear a lot of lawmakers saying, well, we got to deal with this issue because it's not tomorrow. And that's usually how Congress deals with stuff.
Yeah, Congress is good at dealing with things when it absolutely has to be dealt with, and there's some moving forward. One of the things that I've looked at and really spent a lot of time on, and I was just talking with Kathleen Rice yesterday. We walk in the hallways together, and people think, do y'all even talk? I've heard people back home, do y'all even talk to each other? And we do, and she's driving an Alzheimer's moving forward. So if you really look at the aging population, and I'm born in 1964, so I'm the end of the baby boom. In, I think it was 2050, Alzheimer's is going to expected to cost $1 trillion. And so one, you look at just the devastation on the person with the disease, the devastation on the family. That is, we need to have more responses to Alzheimer's because of that alone. But if you look at just to what it's going to do to the federal budget, I was thinking, I need to get involved in this because if, you know, in 2050, what this is going to do to my grandkids or great-grandkids, then I did the math. I said, I'll be 86. I'm that guy. And so it's really what is going to happen to my children. And this is in my lifetime. This is, you know, my generation is the ones who are going to have this expense if we don't have moving forward. And so you get back to how this all ties in together. Francis Collins led, and I told him one of these days we're going to study him like kids study Louis Pasteur and Jonas Salk, because it really is. But you saw what he did with the genome and how it's moved into all now dealing with stage 4 melanoma and the things with sickle cell anemia, which is a tragic disease, and things that we can actually, cystic fibrosis, we can do great things with now that we couldn't. Kids are going to live to be 70 that could only live to be 25. So that's there. This is real. And so the brain research, I think the thing that excites me more than keeps me up at night, what keeps me up at night is how we're going to deal with the onslaught of all of us baby boomers on Medicare.
Right.
But one way to deal with it is the research that's going on in the National Institutes of Health, and the Brain Project is probably what excites me more than anything. And I'm not a physician. I didn't do healthcare. When I first ran for Congress, I never went around and so we talked about, said, send me to Congress and I'll deliver you Spectrum. I'm going to go fight Alzheimer's. That wasn't what I did. I was budget deficits, military is kind of my background. But I got an energy and commerce because I was in state government, and state Medicaid was bankrupting the state of Kentucky. I said, I want to be involved in reforming Medicaid, which I thought we had a really good proposal in our version of repealing and replacing the Affordable Care Act. But having said that, that's what got me on this committee. But going through 21st Century Cures, going through the people that come to your office and tell you the things that they're inventing, the things that they're developing, the things that are moving forward, has made me, I guess, hopefully, Congress's best advocate for the innovation coming out of the healthcare industry. We have to make it affordable. I mean, it's to have a way to cure stage 4 or to deal with stage 4 melanoma, but it costs several $100,000 a year.
Right.
We've got to make that work. We got to figure that out. And if I had the easy answer, I would give it right now. But that's what we're struggling to make sure we have that happen. But what we don't need to do is go to a system that doesn't bring that innovation about. And that's probably my concern if we went to just a single payer like some other, people always talk about other industrialized countries have this, that, and the other. And I'll challenge you to go to Owensboro, Kentucky, and go to our hospital and show me a city anywhere else in the world that has 60,000 residents, 100,000 in the county, that have a medical facility that nice. So we do have access to good care. We just have to figure out how to make it affordable without losing access to good care.
Have you seen a difference in urban and rural healthcare?
You know, you always have more choices.
Well, that's not good.
Yeah.
That would be a first for us.
Yeah.
Hopefully it's just a false
alarm. You know, the difference is, I mean, I live in a town called Bowling Green. We're 1 hour from Nashville. We have 2 hospitals, one nonprofit, one private hospital.
Well, I'm sure our staff will get it checked out in case there's any real danger.
And we're 1 hour from Nashville, so we have the Vanderbilt health system right there. So we're blessed. The farther you live away from that, the more difficult it is. So we'll figure out what we need to do.
Well, hopefully that will be remedied soon and the raging fire will be put out. If anyone wanted to ask any questions, we have just a few minutes left in this session. If you can identify yourself, and I don't know if we have handheld mics coming around, but go ahead. When you ask
Or
the
I
question.
could repeat the question.
Yeah, that's a good idea.
My name is Michael Bates. I'm representing the National Hispanic Medical Association. I'm a second-year medical student at LSU.
Uh-huh.
Something that really worries me, and something I also am really excited about, is that innovation you talk about. They're showing us things in medical school that are absolutely incredible as far as technology. But it's also something that I used to be an ER technician. I know that the majority of them are never going to see. How do you see the government's role in increasing the accessibility of these innovations that, should I repeat the question, or?
Yeah, go ahead.
yeah,
Repeat. Yeah.
National Hispanic Medical Association. My name is Michael Bates. I'm a second-year medical student, and we're constantly exposed to the great innovations that our entire system has been able to produce, and it's absolutely incredible. But something that really concerns me as a medical student is that I'm very afraid that my future patients will never get to see the benefits of some of the most cutting-edge technology in surgery, biosimilars, catheter aortic valve replacement. How do you see government's role in increasing access to this wonderful technology that we have?
So the government's role in it, one is that we need to get more people covered with health insurance. I mean, that's one thing we need to move forward to. And I heard a question that Doris Matsui had. So one is, the Affordable Care Act did increase coverage, one through Medicaid expansion. And there are other things that we can do. Because if you look at who was uncovered, it was mostly people in small businesses who were individual employers, worked for small businesses, because a lot of people got their health insurance through their employer. And then you had expanded Medicaid for the people at the lower end of the level. And what's still the pressure, because I heard the question, is the absolute expense for people who buy on the individual market. So I think there are things we can do. One, associated health plans is a big area where people can pull together to pull their resources so they can afford health insurance. On the innovative technology, I know Kentucky, I think it took a little while, but it did adopt the hepatitis C. Pay for that, they pay for other things. So what we have to figure out, and like I said, if there was a simple answer, I would have given it easy. But as the innovation moves forward, I know health insurance plans have to say, is this something I'm willing to pay for? They do go through the same process to move forward. So I had a bill actually that tried to, because you really can't market your pharmaceutical until it's been approved by the FDA. And the problem is, like, there was a really innovative migraine that came out, and all of a sudden everybody wanted it, but it was on nobody's health insurance plans. So we were getting calls in our office saying, this is out there by my health insurance, because people call their congressman, their health insurance plan doesn't pay for not just Medicare sometimes. And so I had a bill to say, all right, once we're beyond in several stages between the health plans and the pharmaceutical manufacturer, they can have conversations about what the price is going to be, so it can be on the formulary. You would like to see the FDA say, this is approved today, and that next minute it goes on a formulary. I know that's the ultimate, but we don't want a year or two lag either. And so we're trying to figure out how do we get these things approved quicker and how do we get them on health insurance quicker. But the idea of how do we take, some remedies can be hundreds of thousands of dollars and make those affordable through Medicare system. That's something we have to figure out. How do we drive down the prices? I think one, if we do look at how manufacturers are, have some skin in the game throughout the whole Medicare Part D, even in the catastrophic, I'm not saying 70% like they are in the cover, you'd smooth that out, but have some skin in the game and put downward pressure on some of these prices as well. I wish it was a simple answer.
It's never simple. in
Never
healthcare.
simple.
Yeah, yeah. Well, we've run out of time. Please thank the congressman for joining us this morning, and I hand it back to Brittany.
All right.